The questions that ask about the pre-op and post-op assessment are: what is the elective surgery, what are the investigations and complications, what is the regimen for glycemic control. So for the pre-op MI and diabetes mellitus, we will do the following investigations, that is blood sugar level, HbA1c, coagulation profile, lipid profile, CBC, chest X-ray, and RFTs. These are done for the pre-op and post-op assessment of the surgery. ECG is done, echo is done, BP examination is done, PFTs, that is pulmonary function tests, are done, coagulation profile is done, and urea and electrolytes are checked, and LFTs are done. What are the complications of diabetes mellitus or MI? This is hyperglycemia, hypoglycemia, electrolyte imbalance, non-ketotic diabetic coma, diabetic ketoacidosis, infection, stroke, poor wound healing, sepsis, MI, renal failure, neuropathy, and retinopathy can occur due to the MI and diabetes mellitus. What are the pre-op and post-op regimen for good glycemic control? As this patient has non-insulin-dependent diabetes mellitus, so these are at risk of hypoglycemia, which, if unnoticed, could lead to severe brain injury, coma, and even death. Be first on list. Stop morning dose of oral hypoglycemic agents. Have regular sugar check, that is 1 to 2 early. Have intravenous cannula with slow infusion of dextrose and saline. Restart medication as soon as after surgery. As hypoglycemia is more dangerous than hyperglycemia, moderate hyperglycemia is acceptable. Okay, what is the GPI regimen? This is the glucose, potassium, and insulin regimen. Admit 24 to 48 hours before surgery, and once nil by mouth, patient is treated with intravenous infusion of insulin, dextrose, and potassium in a single infusion bag. This is called GPI regimen. If someone asks what is GPI regimen, then it stands for glucose, potassium, and insulin regimen. For MI, despite nil per oral, patient is advised to take medicine even on day of surgery, for example, digoxin plus diuretics. Electrolytes hypovolemia should be corrected, anemia should be corrected, and circulatory volume is maintained by fluids and strict input-output monitoring. Now, what is pre-op jaundice? Prep for surgery. First, prepare this patient for surgery, then do the investigations for anesthesia, then what are the complications. These are the important topics or questions that are asked in the pre-op jaundice. What is the scenario? Obstructive jaundice due to carcinoma of head of pancreas and MI for 6 months back. This is the scenario, and these are the questions that are asked. Now, pre-op preparation of patient. What is the pre-op preparation of patient? First, history is taken. History of cardiovascular diseases, neurological diseases, respiratory diseases, renal dysfunction, previous surgery, anesthesia, medication, drug allergy, and bleeding disorder is taken. Then examination is done and investigations are done. In examination, airway examination fit for intubation is done. Investigation CBC, electrolyte, RFTs, LFTs are checked, clotting screening is done, echo is done, blood glucose and HbA1c is done, chest X-ray is done, ERCP is done, and MRCP is done. Ultrasound abdomen for distended biliary tract. Management of pre-op problems. What is the management? First of all, pre-op biliary decompression improves post-op morbidity. Endoscopic internal drainage preferred over percutaneous external drainage. Intravenous administration of 5% dextrose saline followed by 10% mannitol or loop diuretics to prevent renal failure. Broad spectrum antibiotics prophylactically are given, that is cephalosporin or aminoglycoside. Then oral bile salts and correct the anemia or coagulation profile or hypoalbuminemia. Then paracetamol or vitamin K is corrected. Then cholesterol and antihistamines for symptomatic relief of pruritus is given. Pre-op intravenous fluids and volume expansion is done. Use of lactulose and bowel preparation reduce the risk of hepatic encephalopathy. Now, the preparation of gut for colorectal surgery, how we will do it? Colon is loaded with microorganisms, so it is necessary to empty it before surgery. 36 hours before surgery, start liquid diet and oral metronidazole, and 24 hours before surgery, dissolve 4 sachets of picosulfate laxative in a jug of water and ask patient to drink it. Then nil per oral, and then dinger lactate is given. Night before surgery, how we will do the preparation for night before surgery? Evaluate efficacy of picosulfate, then given at night to patient. What are the complications if not prepared properly for surgery? Hyperbilirubinemia can occur, hypotension, bradycardia, renal failure, hemorrhagic shock, subclinical myocardial infection, systemic endotoxinemia, CVS, autonomic dysfunction, hepatic encephalopathy, and hepatorenal syndrome can occur if the patient is not prepared for the pre-op surgery. Okay. So what we have studied in this, we have studied the pre-op and post-op assessment. In pre-op assessment of MIs and diabetes, first the investigations are done and what complications can the patient develop. Then what is the pre-op and post-op regimen for good glycemic control, and what is the GPI regimen, and what is the preparation for MI. Then we discuss the pre-op jaundice. What is the pre-op preparation for the patient of jaundice? First history is taken, then examination and investigations are done, and then management of pre-op problems are done. Then what is the preparation of gut for colorectal surgery, and what are the complications if not prepared properly for surgery. Now we will discuss the post-op renal failure. The third post-op day, this is the scenario that there is the third post-op day, and the patient is oriented, febrile pulse and BP is normal, abdomen is soft and bowel sounds audible. Now the question is ask normal urine output in 70 kg males, and what are the causes of post-op renal failure, and what are the management options. 0.5 ml per kg per hour is normal urine output. Okay. This is the answer of the question part A, that is what is the normal urine output in the 70 kg men. So it is 0.5 ml per kg per hour in normal urine output. And then the question is what are the causes of post-op renal failure. So these are the causes. In pre-renal, the hypotension and hypovolemia, and in renal, nephrotic drugs and surgical injury to renal vessels, myoglobinuria and sepsis are the causes. Then in post-renal, we have ureteric injury, blocked urethra and catheter. So what are the causes of post-op renal failure? We have pre-renal, renal and post-renal. Then what are the management options for the post-op renal failure? We will be assessing the BP, then pulse, then temperature and then CVP. Then ensure adequate fluid management by daily input-output record. Check serum urea and creatinine daily for full recovery. Check catheters if catheterized either block or not. Then correct the hypovolemia. CVP catheter may require to monitor intravenous volume. Dobutamine is given. Ultrasound abdomen is done for hydronephrosis, and stop nephrotoxic drugs. If all these measures fails, call for nephrologist. Okay, these are the general measurement that we will do for the post-op renal failure, and if it fails, then we will do a call for the nephrologist. So what we learn about the post-op renal failure? We learned that what is the normal urine output in 70 kg men. Then what are the causes? So there are three causes: pre-renal, renal and post-renal. And then we will do the general management, and if it is not efficient or if the patient doesn't recover, then we will call for the nephrologist. Now coming towards head injuries, we have two types of head injuries. These are extradural and epidural hematoma. Okay, we are having a scenario that the patient had hit on cricket ball and he lost consciousness, briefly recovered, but he is confused and having severe headache, and he is having vomiting. Okay, so what is the diagnosis and what is the management? So let's discuss extradural epidural hematoma, that is lucid interval. What is lucid interval? It is period of regained consciousness. Okay, you should remember this, that what is lucid interval? It is the period of regained consciousness is known as lucid interval. What is the definition of extradural or epidural hematoma? Extradural space is potential space between dura mater and skull. It occurs due to injury of middle meningeal vessels, that is commonest cause. What physical signs that patient shows when he relapses into coma are assessed by Glasgow Coma Scale. Okay, the Glasgow Coma Scale is very important. This is Glasgow Coma Scale. In mild head injury, we have 14 to 15 points. In moderate, 9 to 13. In coma, we will be having 3 to 8, and score of 8 or less than 8 is equal to coma. Now let's discuss how Glasgow Coma Scale is calculated. Eyes open. Okay, the Glasgow Coma Scale is for eyes, for verbal and for motor response. In eyes, the score is 4. For verbal, the score is 5, and for the motor, the score is 6. Okay, if the patient opens eyes spontaneously, then the score is 4. If the patient opens eyes with speech, it is 3. If the patient opens eyes with pain, then it is 2, and if none, then the score is 1. Now for best verbal response, if the patient is oriented, then 5. If he is confused, then 4. If inappropriate, then 3, and if incomprehensive, then 2, and if none, then 1. Then the best motor responses or best command 6, that is localized pain, then 5, withdrawal to pain, then 4, flexion to pain, then 3, extension to pain, then 2, and if none, then 1. Along with neurological examination, check mental status, alertness, bradycardia, hypotension, headache, reflexes, cranial nerve assessment. Now how we will manage the patient? First of all, history is taken: history of trauma, consciousness, regained consciousness, restlessness, drowsiness, history of local scalp swelling. Now what examination we will do? We will do the GP, that is monitor pulse, BP and temperature. Then the local examination, that is for focal neurological type. Pupil examination is pyrite rate and Glasgow coma scale. What are the specific investigations that we will do? CT scan of brain is in, that is the investigation of choice. And clot appear as bright biconvex and has well defined borders. Then treatment is done following ATLS guideline. First of all, primary surveillance and resuscitation is done, that is admit the patient, then resuscitate, then clear airways and mouth gag, then endotracheal intubation with positive pressure ventilation, then breathing and then circulation is done. Then the secondary survey is provided, that is head to toe assessment to rule out any abdominal injury, for example splenic rupture. Then hemothorax check, then long bone fracture, neurological assessment is done, and then the care of unconscious patient is done. The specific surgery for EDH it is neurosurgical emergency. Evacuation of hematoma by craniotomy or burn hole manitol should be avoided in EDH. Okay, extradural hematoma. So what we have studied in this section, we have studied the head injuries as extradural or epidural hematoma. We have a scenario that there is history of head on cricket ball. Then the patient lost consciousness. This is known as lucid interval. Okay, and then the patient recovered, but he is confused and having severe headache and he is vomiting. So what is the lucid interval? It is the period of regained consciousness. Then we define the extradural or the head injuries. Then we do learn the Glasgow coma scale, that is eyes open, and for eyes and verbal and motor response. For eyes we have 4 points, for verbal we have 5 points, and for motor we have 6 points. If he opens the eyes spontaneously, then the score is 4. If with speech, then 3. If with pen, then 2. And if with none, then it is 1 score. In the verbal response, if oriented, then 5. If he is confused, then 4. If inappropriate, then it is 3. And if incomprehension, then 2. In the best motor response, we have obeys command, then 6. If localized pen, then 5. Withdrawal to pen, then 4. And inflection to pen, then 3. And extension to pen, then 2. Okay, then we learn along with the neurological examination what we will do: mental status, alertness, bradycardia. Then we learn how to do the management. First of all, we will take the history, then do the examination, and then we will do the investigation, and then we will provide the treatment. In treatment, first of all, we will provide the primary survey and resuscitation. Then we will do the secondary survey, and then we will do the specific surgery for the extradural hematoma. Now coming towards surgical oncology, what is the question that is important for surgical oncology? These are what are tumor markers, how they are used in surgical patients. For examples commonly used for tumor markers, to the tumor marker which they are utilized. Okay, so what are tumor markers? Tumor markers are biochemical substances which can be deleted in serum or excised tissues of patient and are related with presence of tumor. They include cell surface antigens, cytoplasmic proteins, enzymes and hormones. They are not specific but can support diagnosis. Okay, now immunohistochemical markers. Tumor markers which are checked in biopsy or cytology specimens are also known as immunohistochemical markers. For example, CD20 for beta cell neoplasm, CKIT for GIST, and ERPR in breast carcinoma. These are the tumor markers. Okay, you should remember these specific names. What are the uses of immunohistochemical markers? These are used in screening and diagnosis, in monitoring therapy, in prognostic indicator, in early diagnosis of prolapse. Now, what are some important commonly used tumor markers? These are ERPR in carcinoma breast, carcinoma, embryonic antigen for colonic carcinoma, and carcinoma 125 for ovarian cancer, and PSA for prostatic cancer. What are others? These are hormones, B proteins. So LDH, seminoma, lymphoma, beta HCG, choriocarcinoma, calcitonin, medullary thyroid carcinoma, and in proteins we have immunoglobulins and multiple myeloma. The C is antigen, which is AFP in hepatoma and teratoma, PSA for prostate tumor, and CEA for colon and pancreas and lungs, and CA125 for ovarian carcinoma, and CA99 is pancreatic tumor, cholangiocarcinoma. Now, what is chemotherapy and neoadjuvant chemotherapy? Use of chemotherapy prior to treatment is called neoadjuvant chemotherapy. In advanced cases of tumor, neoadjuvant therapy before surgery with chemotherapy, hormonal therapy or immunotherapy is given with the aim of reducing tumor size, extent and burden, enable move curative excision with disease-free margin. Okay, what is neoadjuvant chemotherapy? The chemotherapy which is done before the surgery is known as neoadjuvant chemotherapy, and it is done for the purpose that the tumor size increase. Okay, what are other neoadjuvant chemotherapy? Adjuvant principles of administrations of chemotherapy in cancer patient. Prognosis depend on what? Complications, role of chemotherapy in cancer. These are the important things. Okay, now what is the role or principle of chemotherapy in treatment of cancer? First of all, the chemotherapy can cure lymphomas, leukemias, germ cell tumors as primary treatment. Then chemotherapy is adjuvant therapy after surgery used in combination with radiotherapy to lower risk of recurrence of cancer, for example colorectal tumor. On the third number, chemotherapy or neoadjuvant neoadjuvant therapy before surgery is locally advanced cancers to reduce size, extent, and burden of tumor to enable a more curative excision with disease-free margin. Lower total number of cells in body, reduce likelihood of cancer spreading, shrinks tumor size, reduce current symptoms of cancer. In case of late stage, may help to relieve pain. Can be used in immune system disorders, for example, lupus, rheumatoid arthritis, also in bone marrow cell transplant. Then, what are the complications of chemo in general? These are nausea, vomiting, myelosuppression, alopecia, GIT, neurological, bladder toxicity, myopathy, cardiotoxicity, nephrotoxicity, infertility, hepatic, and secondary malignancies. These are the complications of chemotherapy in general. Now, what is the role of surgery in cancer? Surgery remains the treatment in majority of solid organ tumors. However, surgery has revealed roles in cancer treatment. First of all, it is used in the diagnosing and staging. In majority, diagnosis is done before surgery, but in some cases, surgical procedure is required for diagnosis and staging of the cancer. For example, laparoscopy can be done for intra-abdominal malignancy to get biopsy and to look for small peritoneal or liver nodules. In the second, removal of primary disease, it is used for the removal of primary disease. Radical surgery include complete removal of tumor with adequate tumor-free tissues and drainage lymph nodes. In third number, removal of metastatic disease. For example, liver resection for colorectal liver metastasis can lead to longer survival in absence of any other metastasis. On the fourth number, it is used as a palliation. Sometimes disease is not curable by any means and the surgery is used to relieve symptoms. For example, in advanced carcinoma of rectum that is causing intestinal obstruction, which is relieved by performing sigmoid colostomy. It is also used for prevention, for example, in familial edematous polyps. Prophylactic total colectomy is indicated as chance of developing malignancy is 100%. It is also used for reconstruction, for example, breast reconstruction following modified radical mastectomy. Okay, so what we have studied in this portion, we have studied about the surgical oncology. What is the important question that are asked? That is, what are the important tumor markers, how they are used in surgical practice, and what are the 4 examples of commonly used tumor markers and the tumors for which they are utilized. So first we have defined that what are the tumor markers. Then what are the immunohistochemical markers? The CD20, CKIT, and GIST, and ER and PR in breast carcinoma. These are some of the important tumor markers. What are its uses? Then some important commonly used tumor markers, and then the others are hormones and proteins and antigens. Then what is chemotherapy? What is neoadjuvant chemotherapy? What is the role or principle of chemotherapy in treatment of cancer? Then we studied the complications of chemo in general, and then we studied the role of surgery in cancer. It is used for diagnosis and staging. It is used for the removal of primary disease. It is used for the removal of metastatic disease. It is used for palliation. It is used for prevention, and it is used for reconstruction. Now coming toward our last topic, that is sinuses and fistulas. Okay, sebaceous cyst. These are the questions or topics which are asked. That is, 2 lumps on scalp, painless, slowly enlarging with hair loss fluctuation, test is positive. This is a clinical features which says that there are 2 lumps on the scalp of a patient and it is painless and it is slowly enlarging with hair loss and the fluctuation, test is positive. And the diagnosis is what are the other sites this lump can found, sites where never occur, and composition and treatment. So these are the sebaceous cysts, there is sinus and fistulas, also called epidermoids. Sebaceous cyst is also known as epidermoid cyst. Okay. What are the sites that the sebaceous cysts are found? No, occurs where anywhere in the body where there is sebaceous glands, can be implantation, follicular epithelium, dermis as a result of trauma. Then the sites where it never occur where sebaceous glands are absent, for example, non-hairy skin like palm and soles. So the sebaceous cysts never occur on those places where hairs are not present, for example, palms and soles. Okay. Scalp, face and back, these are the most common sites. That is scalp, face, back and scrotum. What is the composition of the sebaceous cyst? So it is made of keratin material and sebum and dead cells and fibrous tissues and fluid. What are the complications? It can develop complications like infections, sebaceous horns, calcification, abscess formation, Cox peculiar tumor. Now what are the treatment options? Diagnosis on basis of clinical features is done but can be confirmed by histological examination. That is, cyst wall consists of stratified squamous epithelium cyst filled with laminated layers of keratinous material. What is the treatment option? Small small or large, can be excised along with skin treatment, incision, and involvement of cyst with its wall. Now, enterocutaneous fistula. The scenario we are having is the 55-year patient all appendectomy for complicated acute appendicitis. Abdominal sac was inflamed, and after 2 days of fecal fluid began to discharge through the wound. Okay, after 2 days, the pus discharge started. So the questions are: what is the composition? What is the definition? What factors prevent spontaneous healing of this complication? And what are the principles of treatment of these complications? So the definition we are having is: it is continuation of epithelial surface of intestine with epidermis of skin. Factors that prevent spontaneous healing of this complication: it is FP within the fistula tract, radiations, enteritis, inflammation, infection at fistula origin, epithelialization of the tract, neoplasm, and distal obstruction. These are the factors that prevent spontaneous healing of this complication. What are the principles of management of this complication? We have initial management and operative therapy. In initial management, we are having fluid and electrolyte support, nutritional support, parenteral control of infection, that is antibiotics, protect the skin from excoriation, and drainage of intra-abdominal abscess. In operative therapy, we are having the most intestinal fistulas closed spontaneously. 2 to 3 months are allowed for spontaneous closure of fistulas. Sometimes early surgical therapy is needed because of uncontrolled sepsis, complete disruption of anastomosis, and high fistula output. Surgical procedures include salvage procedures, that is drainage of the abscess, proximal diversion of the bowel, exteriorization of the segment of bowel having fistula, and salvage procedure we have resection of the segment of bowel with anastomosis, and in definitive surgical procedure we are having the resection of fistula and include segment of bowel and primary anastomosis. Okay, so what we have learned in this section, we have learned about the sebaceous cyst, what are the clinical features, what are the scenarios, and what are the questions asked. The important things that ask are diagnosis, the sites where lump is found and the sites where the lump is never found, what is its composition, and what are the treatment options. So we have discussed the common sites, and then we have discussed the composition, then what are the complications, and we have discussed the treatment options for large, small as well as large. Then what is enterocutaneous fistula? We have a scenario and the important things, that is composition, definition, factors involved, and the principles of treatment and their complication. We discuss the definition, then what are the factors that prevent spontaneous healing of this complication, then we discuss the principal management of this complication, then initial management, the operative management, and the surgical management. In surgical management, we have the drainage of abscess and the salvage procedure and the definitive surgical procedure. Now coming toward our last topic, that is anastomosis leakage. We have a scenario, that is 50 years old lady, laparotomy. She had resection and anastomosis of bowel on 5th post-op day. She developed abdominal distension, pyrexia, hypotension, and tachycardia. What are the causes and treatment? So here we have a patient who is having a history of laparotomy and resection and anastomosis of bowel, and on 5th post-op day she developed abdominal distension and pyrexia and hypotension and tachycardia. So what are the causes? The definition of anastomosis, the diagnosis we are having is anastomosis leakage, and the definition is: it is defined as a leak of luminal contents from a surgical joint. They are the most important complication to recognize following gastrointestinal surgery. Okay. Now what are the causes? Paralytic ileus is the cause, peritonitis is the cause, bleeding is the cause, atelectasis, abscess, intestinal obstruction is the cause. What are the treatment options? Conservative for small leakage, nil per oral, proximal decompression is done, antibiotic coverage is provided, and fluid aspiration is done, and intravenous fluids are given. What are the surgical options? Surgical repair of anastomosis if generalized peritonitis develop. Okay. So what we have discussed, we have studied the scenario of anastomosis leakage, then we have discussed the causes and the treatment options, and what are the specific surgical options, and the conservative options for the treatment of anastomosis leakage. Here we have ended our surgery subject, and these are all the topics that we have studied in 6 to 7 videos. I think we have covered the general surgery portion. I have give the read to all the topics. We have discussed the shock and hemorrhage, septicemia, burns, blood transfusion, ATLS, aseptic technique and sterilization, nutrition, enteral feeding, parenteral nutrition, gangrene amputation, fournier gangrene, gas gangrene, wound dehiscence, chronic leg ulcer, venous ulcers, diabetic ulcer or diabetic foot, needles and sutures, decubitus ulcer, fluid and electrolyte, surgical infections, necrotizing fasciitis or cellulitis, carbuncle, tetanus, prophylaxis, skin tumor and squamous cell carcinoma and basal cell carcinoma, malignant melanoma, post-op pyrexia, ganglion, DVT, varicose veins, cervical lymphadenopathy, tuberculous lymphadenitis, pneumothorax or chest trauma, and pneumothorax, cardiac tamponade, arterial disorder, there is acute ischemic limb, pre-op and post-op assessment, pre-op jaundice, post-op renal failure, head injuries, extradural hematoma, surgical oncology, then role of the tumor markers in the surgery of cancer, sinus fistulas and cysts and sebaceous, enterocutaneous fistula, and anastomosis leakage. We have covered our general surgery subject, and all the topics that are highlighted here are covered in general surgery. Now we will start the systemic surgery, and we will cover each chapter in a day. That is, the first we will do the breast, then the thyroid, then the orthopedic surgery, then the upper GIT, then the lower GIT, and then the urology, and then we will be done with the surgery subject for our prof preparation. This is the revision method for the SEQs and MCQs. This is a short types of notes from which we can which is helpful to know that which topics are important and what things we should learn and how the scenarios come in the exams and how should we solve it. So if any one of you require the written notes, so please do comment in the comment section that just send us the note, then I will send you these notes. Thank you.